Hello everyone. Today we'll be talking about bradyarrhythmias, the various types of bradyarrhythmias. And this session specifically we will be doing on the based on question and answer type, that is MCQ based, and then giving an explanation for various types of heart blocks. So let's go into the topic. First thing, before knowing about bradyarrhythmia, we should know what is actually bradycardia. So sinus bradycardia is defined as heart rate of less than 60. So bradycardia is normally defined as if your heart rate is less than 60 beats per minute, it's called as bradycardia. So now we'll be talking about Mobitz type 1 block, that is Venki-Back phenomena. So there are three types of heart blocks, that is called type 1, type 2, type 3, and there is high grade AV block. So we'll be talking about the Mobitz is type 2 block, this is type 2A block. So Mobitz 1 block is Venki-Back phenomena. So what do you see in Venki-Back phenomena? There is progressive prolongation of the PR interval. So what happens is, so this is the PR interval, that is beginning of the P wave to the beginning of the QRS. So the time take, so this actually denotes the time taken for the atrial depolarization and the conduction to pass from the atria to the ventricle. So that is what PR interval denotes. So more is the PR interval, that means more is the time being taken for the current or the depolarization waves to pass from the atria to the ventricles. So if there is an AV nodal block, that is our electric activity starts from SA node, which is the pacemaker, and from SA node it goes into the AV node. So if there is defect in the AV node, so that's why there could be prolongation of the PR interval. So PR interval is prolonged. So normal PR interval is less than 5 small squares. It's actually in the range of 120 to 200 milliseconds. That is, it should be less 3 to 5 small square, and it is less than 5 small square usually. Here you can see it. Here it is actually around 6 small squares. So there is 6 small squares. So it means there is PR is prolonged. So there is some defect in the AV node, and then you can say as in such the time passes, there is a prolongation of the PR interval. See, which each bit the PR is getting prolonged. Here it is 6 small square, here it is around roughly 8 small squares, and then here around 9 small squares, and there is prolongation. Followed by prolongation, what happens is that later on the AV nodes get fatigued. So, so AV node, there is defect in AV node, so it allows the current to pass up to some extent, and it gets slowed. So with each time it keeps getting fatigued, and after a time it completely stops conducting, and that's why where you get a skip beat or a drop beat. So here you can see, what do you mean by drop beat is that there is a P wave. So it means atrial depolation has started, but this depolation wave is unable to pass through the ventricles. That's why there is no QRS. So you can see P wave, but there is no QRS. So that means it's a drop bit. That means AV node has completely stopped functioning at this part. So that is a drop bit. So this is a characteristic feature of a Mobitz type 1, that is progressive prolongation of the PR interval with each bit followed by a skip bit. And what is other most important two things is that the PR interval is longest. The PR interval whichever is there is longest before the drop, and it is shortest after the drop. So here there is progressive prolongation. So just before the drop, this PR interval is the longest, and just after the drop, it is the shortest. Other features of Mobitz type 1 is the PP interval remains relatively constant. Okay, what does that mean? That these P waves, each P wave will come within the same interval. So same same time is required for each P wave, but only thing which is changing is the time taken for AV node to depolarize. Okay, but the RR interval may get shortened. RR interval progressively shortens with each bit of the cycle. So what is the mechanism of Mobitz 1? It's usually due to reversible conduction block at the level of AV node. As I already said, there's a defect in the AV node. So there is reversible conduction block at AV node. What are the causes of Venki-Back phenomena? Is most common is drugs. So any drugs which will cause bradycardia or which is acting on the AV node, that is beta blockers, calcium channel blockers, digoxin or amiodarone, or increased vagal tone. You can see which is seen in which is seen in athletes or who are doing high intensity sports activities. Inferior wall MI. Why do you see it in inferior wall MI? Is that the inferior wall MI is most commonly caused by right coronary artery occlusion, and this right coronary artery supplies the AV node and SA node. So it supplies the AV node and SA node. So that's why if AV node is damaged because of occlusion, it could be lead to bradycardia or various types of heart blocks, myocarditis, and following a cardiac surgery. What is the clinical significance is that Mobitz 1 is usually a benign rhythm. It almost recovers on its own. For example, if it is because of the drugs, if you stop the drugs, the patient rhythm may get completely normal, and there is very minimal hemodynamic disturbances, and it has very low chances of progression to third degree block. So this heart block is a very good heart block. That means it is reversible, it doesn't causes very much damage, and patients generally recover very well. And they usually respond to atropine. And permanent pacemaker is usually not required. So now we are talking about the first degree heart block. This grade 1, that is first degree heart block. As I've already said, the first degree heart block is basically if we are all talking about the AV blocks here, basically involving the AV node or bundle of his blocks. We're not talking about the sinus node defects here. So normal PR interval is 120 to 200 milliseconds. If your PR interval gets prolonged, that means PR interval more than 200 milliseconds or more than 5 small square, then it is called as, it comes into first degree heart block. Okay, and there is, so but the only thing you should compare it with Mobitz one is that there is no progressive prolongation. So PR interval remains constant throughout, but it is just prolonged in time, and each PVP is followed by QRS. And so that, what does that mean? There is no skip beat. You've seen in Wenckebach phenomena there is a skip beat which occurs, but there is no skip beat here. And marked first degree heart block is present if PR interval is more than 300 milliseconds. So causes of first degree heart blocks are similar to that of the Wenckebach phenomena, that is increased vagal tone, athletes, inferior wall MI, electrolyte disturbances, and drugs causing that. Clinical significance again, it has a very limited hemodynamic instability, and is usually a good heart block. That is, it responds to treatment very well. Or if you find the cause, if you treat the cause, it will get reverted to normal rhythm, and no specific treatment is usually required. Next, we will talk about the Mobitz type 2. Mobitz type 2, the PR interval is actually normal. There is no prolonged PR interval, or also there is no progressive prolongation, but there is a skip bit. So what will happen is that there is intermittent non-conducted P waves. So there is no progressive prolongation. You can see this is a P wave, QRS, then P, QRS. There is no progressive prolongation. Neither the PR interval is prolonged, but after a particular few number of beats, there is sudden drop in a beat. So see here you can see only P wave is there, but there is no conduction to the ventricles. So that's why it is what is called as Mobitz type 2 heart block. So how will you differentiate it from the type 1 is that in type 1 there is progressive prolongation. The PR interval keeps getting prolonged every time. See here. So this is Mobitz type 1. You can see here the PR interval is keep getting prolonged. It is increasing, and again it has increased from here to here more. But in Mobitz type 1 there is no prolongation. And also there is a followed by skip bit. So skip bit is present in both Wenckebach type 1, that is Mobitz type 1 and type 2. But here there is no progressive prolongation, and PR interval also remains normal. PR interval remains constant. The PVS march through at a constant rate. Okay. So Mobitz type 2 is basically because of the failure of the conduction, which most commonly occurs at the level of his Purkinje system, that is below the AV node. So current normally passes from SA node to AV node, and from AV node to bundle of his. If there is defect in bundle of his or Purkinje system, so this gives rise to what is called as the Mobitz type 2 heart block. So in 75% of case, the conduction block is actually located distal to the bundle of his. The defect is distal to bundle of his in 75% of cases. So whenever there is a defect in bundle of his, what will happen is that the ventricles will start acting as their own pacemaker. And whenever the ventricle start acting as a pacemaker, ventricles functions very slowly. It's not very fast, and that's why it produces what is called. So everything gets prolonged, and there's a broad QRS. You can see here broad QRS complex. So, but Mobitz type 2 can also have a narrow QRS complex if the block is within the bundle of his. So, and not distal to bundle of his. So if the bundle of if the block is prior to bundle of his, you can see is narrow complex, that is as seen in this. And if it is post bundle of his, there's a broad QRS as seen in this ECG. Cause of Mobitz 2 is again it mostly commonly seen in anterior wall MI, not inferior wall MI, because the bundle of his and Purkinje fibers and all are actually supplied by left anterior descending artery. So left anterior descending artery is mainly the cause for anterior wall MI. Inferior wall MI is mostly caused by right coronary artery, and right coronary artery supplies only SA node and AV node. It doesn't supply bundle of his. So if there is anterior wall MI, there are more chances of Mobitz type 2 block. The other causes is drugs, hyperkalemia, autoimmune causes, and post-cardiac surgery. Clinical significance is very much important because the defect is in the bundle of his and below that. So the heart rate will be low, and it will more likely to cause hemodynamic compromise, and there are high chances that it may progress into third degree heart block. And it definitely mandates an immediate admission. So patient should be immediately admitted and should be immediately put on a temporary pacemaker, followed by, if the cause has been treated or the Mobitz block is not getting reversed, you should definitely, patient may need a permanent pacemaker. Then we have a complete heart block. So ECG phases of complete heart block occurs when there is absolutely nil conduction of AV. So that means the AV node has been completely cut off. There is no current which is passing from the atria to the ventricles. So atria will start beating on its own and ventricle will start beating on its own. So there is no relationship between them. It is called as AV dissociation. You can see here each P wave will come and in within the same interval. So here you can see PP, and QRS will beat at the same interval. So that is, distance between two RR wave is similar throughout, and distance between two P waves is similar throughout. But you can see there is no relationship of P with the QRS. So P has from here, QRS has came, but then again P has occurred here. The QRS has occurred after some time. So there is no relationship with P and QRS. That is, AV dissociation is definitely there. Pathophysiology is, this complete heart block is essentially the endpoint of either the Mobitz 1 or Mobitz 2. Most important causes are inferior wall MI, then is AV node blocking drugs and idiopathic degenerations. Clinical significance: if the patient is not treated immediately, there are high risk of ventricles getting stopped and sudden cardiac death. Patient should be immediately put on temporary pacemaker followed by a planned permanent pacemaker. So there is one more entity which is called as AV block or second degree AV block. There is high grade AV block. So this has to be differentiated when with compared to complete heart block. In high grade AV block, but it is a second degree heart block where actually there is a PQRS of, so there is there is a block in AV, but this block is in a high grade of block. So that is 3:1 block. So what does that means is that the atria will contract 3 to 4 times, followed by which there will be one QRS. So initially 2-3 times the atrial depolarization will not be passed on to ventricle. Later on only a single one will be passed here. So there's very much, the AV node is very much defective, and only it passes in between 1 or 2 drops. In one between few it passes. So you can see here one P wave, other P wave, and 3. So 3 P waves has came and followed by one QRS. Again 1, 2, 3, and even this here you can see T wave and P wave has merged actually. So 1, 2, 3, 4. There is 4 P waves followed by one QRS. So how will you differentiate that? And also the distance between the each PP wave will be similar, and the distance between each QRS wave is similar. So how will you differentiate between complete heart block and that? Is there is some degree of association. You can see here distance between the P to QRS is similar here. PQRS here is also similar to that of this one. So definitely there is some relationship between atria and ventricle. So this relation, if found, it is called as high grade AV block. Plus, just let's revise this. So you can see this ECG. ECG is may not be looking like a bradycardia, but definitely you can see here. You can see one P block P here, PR interval here, and PR interval is getting prolonged, again prolonged and prolonged, and again P wave has suddenly dropped here. There is no QRS after this P wave. So this goes into favor of Mobitz type 1 block. Another ECG which you can see here again P wave here, one P here, one P here. So 4 P has occurred and then QRS has occurred. And always here also then 4P then QRS. So and the distance between P to QRS is similar in all the wherever the QRS is formed. So it goes under high grade AV block. Now you can see here. So P so this PR you can see it is very much definitely prolonged. There is around 6 to 7 small square, and prolonged is similarly in all the leads, and there is no drop bit. So it doesn't comes under Mobitz 1. It is a type 1 heart block, that is first degree heart block. Then you can see here this is a P wave, this is a P, this is a P, then QRS, then P here come again P, again P here. There is no relationship between the P and the QRS, and both are beating independently. So there is AV dissociation. It's called as complete heart block. So hope you have liked my video. If you have any queries or any doubt on this topic, do let me know in my comment box. If you want to see more interesting videos, please subscribe to my channel Akif Baig. Thank you.